Doctors can often be particularly interested on progression in progression-free survival, overall survival. Why is quality of life so important in your view?
Because it includes the patient's perspective. I mean, this is something which has become more relevant nowadays, to include not only the physician's position, but also the side of the patient, which means we are moving from a more paternalistic decision-making to a system-making where the patient is involved.
Could you give me the details of what you did in this registry study that you're reporting now?
Yes. This is a huge registry which was initiated by the European Leukemia Net. Actually, there are 17 countries from Europe which are participating. There are more than 100 centers involved. Goal of this registry is to register low-risk IPSS, low-risk MDS patient within 3 months of initial diagnosis. Primary myelodysplastic syndromes are included, and goal is to document demographic data, clinical outcome, treatment in daily life in Europe. And it's certainly the largest and the highest quality registry in the world.
And how did you look at quality of life with these patients?
Within the registry, there are several scores or parameters which are applied, which include performance state, which include comorbidities, and an essential point is to assess quality of life. Quality of life is assessed by the so-called EQ5D, which is the European Quality of Life instrument, 5 dimensions. This is how this acronym is explained. It's a simple and robust score, which includes 5 questions and 1 visual analog scale.
And those questions, are they directed to the patient?
Yes.
So these are patient-reported outcomes?
These are patient-reported outcomes. And an important point is that we evaluate quality of life at initial diagnosis and every 6 months, which means we have a median observation time which is now around 4 years. So we have a lot of patients where we have more than 10 or even 15 follow-ups.
Could you give me the details of what you discovered then?
We discovered that quality of life is restricted in a relevant proportion of patients. EQ5D is measured in 5 dimensions, which are usual activities, which are mobility, which are functional activities, which are pain and discomfort, and which are anxiety and depression. And we see in mobility restrictions in about 13% of all patients. And for the other dimensions, we have restrictions in 40 to 50%, which is a huge number.
Can you tell me about the factors that were influencing those that came out of your research?
We realized that age impacts quality of life, which means the older you are, the lower is your quality of life. I mean, this is differential for the distinct dimensions, which means, for example, with anxiety, depression, or pain, you have an increase around age of 50, and then it levels off. You have other dimensions where you have a kind of linear increase, for example, for mobility. It's a kind of linear increase. Secondly, we found that there's a strong impact of gender, which means women in general have a lower quality of life, a lower perception of their quality of life. Quality of life is associated with comorbidities. It is associated with performance state. And what is quite important, hemoglobin levels impact quality of life largely, and transfusion need.
What about polypharmacy?
Polypharmacy too is a quite strong predictor of quality of life.
Of course, it's part of the comorbidity angle too. Mm. So what do you think doctors should be doing about this?
I mean, these findings are certainly relevant because it's a kind of structured evaluation in a very well-defined large cohort, because actually we have more than 1,500 patients who filled out the form, so it's a huge number. We have a well-defined cohort, so which means we are laying the ground, we are laying the basis for the analysis of prevalence of reduced quality of life.
For doctors, what are the message that you would like to give out at this point about taking notice of patient-reported outcomes and quality of life in myelodysplastic syndrome?
I mean, an important point is certainly that a huge amount of patients have reduced quality of life, so doctors should be aware of that fact. Secondly, we are trying to figure out which factors might be influenced to improve quality of life. Because age and sex cannot be influenced, but we could try to improve hemoglobin levels, we could try to reduce transfusion need. That might result in an improvement of quality of life. We should try to integrate quality of life in combined outcome sets, which means overall survival, progression-free survival, and in addition quality of life.